Okay, so the schedule for the next 3 weeks, 2 weeks, counting this week. Next week is your week that you take your HESI exam, right? Okay. And whatever day you're scheduled is good. So your HESI, and we don't have class in week 11. Okay, so you won't see me next Wednesday, unless you want to meet with me. Okay, so we will not have class. When you're taking your HESI, that's considered your class time for attendance purposes. All right. Week 12, you need to meet with me either Monday or Tuesday. Sunday, I'll have to open up Sunday because I have a lot of students. So we need to set up time. And what you're doing is you're meeting with me once you finish your remediation or as you're doing your remediation. Okay. And it's just a way of taking attendance. 10 minutes tops is all I need you to meet with me. So when we get done class today, if some of you want to go ahead and set up that time, if you don't meet with me, that just means you don't get attendance for week 12. Okay. So if you've missed a lot of class already, you better meet with me. Okay. If you haven't missed any class, then, it doesn't hurt you not to meet with me. But still, if you want to talk about anything at all, it would be good. Okay. So the HESI examination is a goal. In other words, your goal, what you want to attain is a 900. And that's not conversion score. That's just a HESI raw score. Okay. 900 is the goal. Even if you have a 98% average in the class, please do not just blow it off and just do some and don't worry about it. Do the best you can. You want to prove to yourself and to Fortis what you've learned this quarter. Okay, so do the best you can. If you end up with a score less than 900, you're going to have to do, actually, everybody has to do remediation, okay? So what will happen once you finish your exam, your HESI exam, HESI will send a report to you in your account, your HESI NextGen account, of remediation that's required. They give you a packet of information that you have to do, okay? And it depends on what your score is. If you score 850 and above, you need 1 hour of remediation. If you score less than 850, 799 to 800, or 799 to 849, I'm not even sure what the numbers are. I put it in the announcement. You'll need to do 2 hours. So the lower your HESI score, the more remediation you'll be required to complete. If you do not complete your remediation, your HESI score will be 0. Okay. So you are required to do remediation. Okay. So I can look up your remediation time and what you're working on. So you don't have to tell me what you're doing. I can see your work and I can let you know when you're finished. Okay. So you might not need to finish all of the packets. It's based on the time you spend. Okay. And then meet with me. All right. So your remediation is due Tuesday, and I believe it's initially, I think I put it in the calendar wrong. So it's due Tuesday night, the 27th. Tuesday night, the 27th at midnight. Okay. Your homework for that previous week, your next gen newborn quiz and your discussion 5 was just, there's no research involved with discussion 5. You're just going to post something you've learned for the class. It's very simple. Okay. And easy 20 points. Okay. So those 2 things need to be completed by the 26th. You don't have a grace period for week 11 homework. Okay.
Since it's just about what we learned in the class, do we have to give responses to other students?
No, I'm not going to require. I'm glad you asked. I'm not going to require
Thank you.
that you respond. No, unless you want to.
When are we gonna be able
Sometimes,
to sign up for our HESI? Because I can't register for mine yet.
I can show you that after class today. You have to go into your HESI Next Gen, and I can show you how to do that, okay?
No, I have the thing, because I've already registered for my med-surg HESI, but I can't register for maternity.
Yeah, it's
But
not
you
showing
don't-
up for us at Pensacola.
Yeah, we have no time, we have no clue what time. we're
You
supposed
have to
be
change your cohort in the HESI or in the Evolve in order to find it.
See, I can't remember. Are you doing yours with Proctor U? No, on campus. Okay, okay, on campus. All right, I can show you how to do that. If your exam doesn't show up, it means that you got to change your cohort, like Ashley said. And what you do is just go find your name, get onto Evolve, your HESI Next Gen, click on your name, and then your cohort will come up. And so just clear it. And then go back and you should see your maternity exam. And then you should be able to register. Okay. We can work on that after class today. Now you are able, I opened up all of the next gen quizzes that are left. The labor and delivery and the postpartum and the next week's newborn quiz. Now these 3 quizzes you do on your own time, they're homework, but they have a lot of weight. So if you're behind in your homework, if either you haven't done well or you've missed a lot of homework, you better do those 3 quizzes and you better get as high a grade as you can get, okay? There's 20 questions in each quiz. You know, expect yourself to get all 20 questions correct, okay? Don't miss them. It's a grace period almost for you to get some extra points for your homework, okay? Same thing with the HESI RN practice exam. Don't rush through that. Those are good resources to prepare you for the HESI. If you've already submitted your NCLEX and you didn't submit a score above 80, resubmit it. Do some more, get a higher score, okay? And resubmit. Just consider it study time. And you can choose any category you want. Whatever you feel the weakest in. Is it the intrapartum during labor and delivery you feel the weakest, or is it high risk stuff? So what I am doing, my class on Monday, I recorded it and posted it in their announcement. I also posted it on your Canvas page. And then today's class will be recorded and I'll add it to this one and I'll put it in all the other groups. So you're going to have all 3 classes plus all the other instructors' classes in the announcements for week 10. Okay, so you're going to be able to listen to all the instructors 3 times if you want to. That's just a resource for you because they're probably all doing different things. The PowerPoint I used last on Monday is not the same one I'm using today because I have 3 separate PowerPoints I'm using. But you have access to all of them. Okay. Just the more you have, the better off you'll be. The more times you hear something from a different angle, the better off you'll be. And take notes while you're watching them, because when you write it down, like if you can't remember the 5 P's of labor effects, the power, if you can't remember it, then write them down. You might not ever have to look at them again. But once you write them down, there's some kind of process that goes on in the brain that you retain it better if you write it down. Okay. The same thing with veal chop. Write it out. Because I know a lot of you here are visual learners. Majority of people are visually learning. Okay. So if you want to go over exam 3 with me, let me know. If you didn't, get a high enough score, an 86 or higher, you need to go over it with me. There's really important concepts on that exam, and I want to make sure you do understand them. Okay. There are 2 concepts that a lot of you missed. One was newborn apnea. When you stop breathing, it's called apnea. There's no breathing taking place. For a newborn, it's kind of common, as long as it's less than 20 seconds. If it's less than 20 seconds, if you have a newborn and they stop breathing and it only lasts 12 seconds, then you're going to just document 12-second apnea episode. Okay, and certainly you're going to monitor the baby. But if it's beyond 20 seconds, you need to intervene. You need to stimulate that baby, maybe do some positive pressure ventilation. Okay, but anything less than 20, you don't have to. And the other one was the C-section client who had tachycardia. Anytime you have a client that comes to you from surgery, so this isn't only a C-section, this is any kind of surgery. If they develop tachycardia and they didn't have it prior to surgery, then you need to be concerned that there might be bleeding internally. Okay, tachycardia is a sign of fluid volume deficit. Okay, so the most important thing you can do for that client is another IV access. Okay, so a cesarean client that comes to you, she just delivered a baby cesarean, and they monitor in the recovery area for 45 minutes or an hour, and then you receive her as a client. Within a couple hours, if you notice her heart rate is going up, she's tachy, she might very well be losing blood internally, not at her incision necessarily. Her incision might look fine, but her bowel might have been nicked during surgery, or her bladder might have been nicked and her bladder is bleeding. Her colon is bleeding. The uterus is bleeding. The uterus itself. Okay, so you need to get an IV line in before you do anything else.
Is
You
that
don't
what
have to
you
check.
consider? Is that what you consider hypovolemic shock?
Yep. She's not necessarily in shock yet, but she will be shortly. If she has tachycardia, yes. Diaphoresis, tachycardia. Poor perfusion. Okay, so that was the other one most of you missed. I shouldn't say most of you, a lot of you missed. Okay, Nicole, it should be. It should be. Okay, so check with your.
I was just asking because last time I took the HESI and it looked like that. It wasn't
Okay.
with the
And
time
you're taking yours on campus, right?
Yeah.
Okay, so just tell whoever's proctoring you on campus and have that information.
Okay.
Okay. And remind them. And you can even remind your dean now, Dean Carwee. Okay.
Okay. All right. Thank you.
Yeah, do that. Okay. Let's see. What else?
Dr. Zill, I have a question, ma'am.
Yes.
It's about the cohort thing. I'm trying to look for the HESI right now. I'm supposed to be done in December, and that's not even on the list. Do you have any
No,
idea what?
okay, just clear it. Just clear it. You don't have to put anything new in it. Just clear it
Okay.
out.
Okay.
Yeah, just clear it out and see if you can find it.
Community maternity. There it is. Okay.
All right.
Now there's
So you
one
can go in there.
The first one in parentheses is NLIN and HWOO only. Is that's not the right one, is it?
That's not the right one. There should be
Okay.
another one
Do
there.
the other one. Okay, cool.
Yeah.
Awesome. Fantastic. Thank you, ma'am.
You're welcome. You're welcome. Okay. All right, let's do some review. All right. So this is a PDF, so it's not going to be like the same thing as you had before. So, which is nice thing about a PDF that you can print it out with like 2 or 3 pictures on one page and take notes. So take notes. Nagel's rule. You need to know Nagel's rule. What is Nagel's rule about? Why do we do it?
So
It's
it's
to
to keep
estimate your
Or due date.
delivery, your due date.
Okay, yeah, due date. So we're going to take the first day of their last menstrual period, subtract 3 months, add 7 days, and add a year. Okay, so for those of you who are super visual, just remember the pictures. Okay, whatever it takes, right? All right. So gravidity and parity. Gravidity, remember, is the number of times a client has conceived. And then the parity portion, the TPAL, is the outcome of each of those gravidities. Okay. A parity would be those outcomes that reached 20 weeks and were delivered. Okay. Full term is starting at 37 weeks. Preterm is 20 weeks and beyond. What do we call a pregnancy delivered at 17 weeks?
Is it an abortion?
Yep. An abortion. Remember, a stillbirth, if it's a preterm, if the baby died in utero at 32 weeks and was delivered, it's a preterm pregnancy, but there's not going to be any living children. Okay, so it's just going to show up in the parity, but not in the live births or living children. And the twins, a twin pregnancy is just one pregnancy. So that those 2 babies will show up only in the living children, not in the pregnancies. Okay. So you have a client, she comes in for her first prenatal visit and we find out her obstetric history. A girl was delivered at 37 weeks. She had a pregnancy loss at 18 weeks, delivered a boy at 35 weeks, and had 1 induced abortion last year. What's her GTPAL? How many times did she get pregnant?
4.
4 times. So her G
Okay.
is going to be 4. Okay, so the first one, 37 weeks. Is that a
There's
full
4 of them
term?
on this
That's
list.
a
Wouldn't it
full
be 5?
term. So her T is
Oh, she's
1.
pregnant now. You're right, Mitchell. Yeah, so it's a 5. Sorry. See? So full term. How many full terms?
1.
1. How many preterms?
1.
Did 1.
Just 1. They're 35 weeks. Yeah. And then she had
Abortion.
2 abortions. Yeah.
Yeah, 2.
Mhm. And then how many living children?
2.
2.
Yeah. Yeah, don't forget if she's pregnant to add that into your G's.
You
All
missed
right.
it too.
I missed it myself. Yes, I did. Don't laugh at me. That's why it's good to reread it. Okay. And how many times have I used this PowerPoint? Okay, so we have another case, a multigravida. What is a multigravida? What does that mean?
Has been pregnant, has been pregnant multiple times.
Okay, 2 or more. Okay, 2 or more times. She gave birth to a boy at 30-week gestation, a 36-week gestation girl, and a 34-week stillborn. So what's her G?
Three.
3. Yeah, 3. Full term?
0.
No, full term. Preterms?
Oh, there's a term.
Yeah, you're right. No full term babies. Right. What's preterm?
It would be 3 for the preterm.
3
Three.
preterms. Okay, good, good. How many abortions?
0.
0. She had
None.
No.
And then living children.
2.
2.
Yeah, yeah, good. That was easy. Physiology of pregnancy. So I was talking to a student this morning about understanding the importance, and I know I talk about this at the beginning of every quarter. If you understand the blood flow, the importance of blood flow from the uterus to the placenta, and how important it is, then you will understand more about what would happen if that blood flow was reduced. Okay, so remember, we have a lot more blood volume during pregnancy, a lot more plasma. So there's a dilutional type anemia or a physiological anemia. Okay, the blood vessels in the body are much more relaxed, so they can contain more blood. And that's what keeps the blood pressure down. Okay, so the uterus is growing, right? Growing bigger, and a whole lot more blood is circulating in the uterus in order to support the placenta, to support the fetus. Okay. During pregnancy also, because the blood tends to be pooled more, and because the blood tends to clot a lot easier, she's at risk for blood clots. And her varicosities, if she has any varicose veins, they're going to be worse in pregnancy. If she has hemorrhoids, they're going to be worse in pregnancy. She might have nasal congestion. She might have bleeding gums. And this is because of the excess blood and the relaxation of blood vessels and the congestion of the blood in the nose. Okay. She might feel a little lightheaded. And this, you can watch these videos. These are still active to help you understand some of those things. And there's the clotting factors if you need information on clotting factors. Carrier screening. We want to know if mother has any abnormal genes that she could pass on to her fetus. So it's called carrier screening. Okay, so autosomal recessive, cystic fibrosis, sickle cell. Okay, so if a mother is carrying that abnormal gene for cystic fibrosis and her partner, the father of the baby, is also carrying that gene for sickle cell, then the child that she's carrying has a 1 in 4 chance of having the disease, cystic fibrosis. Okay. And 2 of her children will also be carriers. And 1 child will neither be a carrier or nor carry the disease. That is what we call carrier screen. Are you carrying the sickle cell gene? Okay. Or are you carrying the cystic fibrosis gene? We can do carrier screening on anything. You know, if there's an outside of pregnancy, if there's a family history of some kind of cancer, we can actually do carrier screening for cancer genes, especially breast cancer in women or ovarian cancer. If there's a family history, we certainly want to screen, test the women in that family for those cancer genes. And a lot of times we do like a prophylactic surgery. If she carries a gene for ovarian or breast cancer, we're going to do, when she's done having children, we're going to go ahead and do a bilateral mastectomy and a BSO, which is a bilateral salpingo-oophorectomy, removing her ovaries and her tubes and her uterus, taking out all her female parts so she doesn't, so we're reducing the risk of cancer. That's really a tough decision. Really a tough decision. So, but it's carrier screening, same thing. Okay. Fetal testing. If we have a client and her fetus, if they're considered high risk, we got to keep an eye on, right? We're going to have to survey, keep an eye on it, that fetus, making sure that fetus is growing, has plenty of amniotic fluid, is moving. So we can do an amniocentesis. If we have an abnormal AFP, I don't have the AFP in here, do I? No. Who remembers the AFP? What is AFP? Alpha fetoprotein. What does it tell us? Anybody know? Anybody can tell me?
For the any defects like tubal defects or something like that?
It's a low levels versus high levels of AFP. So it's the serum markers. AFP is a marker in the mother's blood, right? We want to see certain levels in pregnancy.
I don't remember like exactly, but I know if it's high is like Down syndrome.
No,
Low?
if it's low, it's down, because low is down, low down, right? Low AFP means increased risk for Down syndrome. High AFP, increased risk for spina bifida or a neural tube defect of some sort. The neural tube, remember, is a spinal cord, right? That whole tube, the nerves, the development of the nerves. And the brain, of course. We can do an amniocentesis. So if we have high or low AFP levels in mother's blood, and we do that after the 11th week, between the 11th and the 20th week, we can do an amniocentesis and do that same test on not the blood, but the amniotic fluid and look at the AFP levels, which is a little more sensitive, okay, a little more accurate, okay? I need to add that to this slide set. Okay, so third trimester, we can also do an amniocentesis. So an amniocentesis is a very invasive procedure. In other words, it's a risky procedure because we can cause damage. What are some things that are at risk if you do an AFP? I'm sorry, if you do an amniocentesis?
Pop the sac.
Okay, so we can actually rupture the membranes. Okay.
The fetal loss of the baby.
Okay, fetal loss, fetal infection, injury,
Injury.
injury to mother,
Premature labor.
premature labor. Yes, all of those things. So what do you want to do after amniocentesis? What are some nursing considerations after the procedure is completed? What do you think you need to monitor or watch for?
Infection.
White blood cells.
Okay, you might, but probably fever, uterine tenderness,
Well, fetal heart rate.
fetal heart rate. Yeah, so we're going to monitor for probably for an hour, and then we can send her home. Okay. All right. So doing an amniocentesis in the third trimester, Remember, this is invasive, so we need to get a written informed consent. Okay, we need to get her consent. She needs to understand the risk associated with this. Okay, so for the third trimester, we can measure the substances, lecithin and ceramyelin, okay, what their ratio is, the LS ratio, and it should be 2 to 1 if the lungs are mature. Okay, if we choose to check lung maturity at 34 weeks, if she's having preterm, she has a history and we want to make sure the lungs are mature, we can do an amniocentesis and check the LS ratio. We don't do it as much anymore because it's invasive. Okay, and it would, if it's not at that 2 to 1 ratio, it means that there's not sufficient surfactant. Okay. Remember, surfactant is a slimy substance inside the alveoli that allows that alveoli to expand and provide oxygen to the blood that's around it. Okay, the blood vessels that are surrounding that alveoli receive oxygen from the alveoli. Okay. Non-stress test, reactive or positive is good. So somebody explain it to me, although it's here. So we're going to put that monitor on baby, just the baby monitor. And mom's going to press a button if she feels the baby move. Okay, and we're going to look at the monitor. Did the baby's heart rate go up when the baby moved? And that's what we want to see. Okay, because movement demands the heart to move a little faster. Okay? So it just indicates that the fetus is getting good oxygenation during movement. Whereas a contraction stress test, we want a negative result. We don't want to see decelerations, okay, during movement or during a contraction. So a contraction stress test is going to tell us how well the fetus will tolerate labor. So once again, monitors, we're going to do 2 monitors this time because we're going to start some contractions. During that contraction, did we see a deceleration? Okay. So positive is bad. Ultrasounds are non-invasive. It's just a probe that sits on top of the belly. We can look at baby's anatomy. We can watch growth. The machine itself will measure the biparietal circumference and diameter. It will measure the length of the humerus, and then it does calculations and tells you what percentile growth that baby's at. Because we can only do that every 3 weeks. Okay. So we can say, yes, we've got some growth restriction. Our fetus has growth restriction. What clients would you expect to be at risk for intrauterine growth restriction babies?
Is it parents with on substance abuse?
Okay.
Diabetes.
Diabetes, maybe.
Smoking.
Smoking for sure. Nicotine. What else? So intrauterine growth restriction, once again, relates back to the health of the placenta, right? Adequate blood flow. If she is smoking, nicotine is going to squeeze those blood vessels. So the blood flow of the placenta is going to be a little reduced. Baby's going to be smaller. Okay. What else causes poor placental health? Besides nicotine, substance use?
Diet?
Nutrition. Nutrition. Yes, nutrition. One more thing. nutrition, nicotine, substance use,
Diabetes.
actually two more things. We said diabetes, which is, okay. Adolescence, just adolescent age, okay? And then high blood pressure, chronic high blood pressure. So there's like 6 things. Anything that reduces blood flow or reduces the quality of the blood. Inadequate folic acid, inadequate nutrition, reduces what the baby gets. So intrauterine growth restriction. Okay. Daily kit counts. So what client would you want to teach about daily kit counts? And these are 3rd trimester. Anna, if you're talking, you're muted.
I'm sorry.
Danae, what client would you want to teach about daily kit counts?
Did you say me?
I was saying, oh, I'm sorry, Danae.
Oh,
Danae.
I'm not sure.
You're not sure?
Being like high risk.
High risk? In what particular high risk? I mean,
41
when would you want-
Pre-eclampsia patients.
Yeah, maybe.
pregnant 41 weeks.
41 weeks, definitely. Post-term, yes, yes. Catrice, what about you? What do you think? When would you want to teach your client, watch your baby movements? Make
20
sure
weeks.
baby is moving. Huh?
20 weeks.
Not at 20 weeks. We're not
No.
worried about it. We're talking about that 3rd trimester. What do you think? What clients? This might be a little more challenging with your thoughts.
What about placenta previa patients?
Not necessarily. No, for placenta previa, you want to teach her to watch her bleeding. Okay. What about that baby that's not growing well? We want to make sure the baby is thriving, and a baby that moves a lot is a good sign. Okay. So intrauterine growth restriction in adolescent, or any client that says, I can't feel my baby move. I don't think I'm feeling my baby move. We're going to teach her about counting every hour, or at least 1 hour throughout the day. Okay. Okay. That was a little challenging. If she's not feeling, then we need to do some assessments. What's this?
Dirt.
That's dirt. And there's a fork in it. What can we assume? Pica, yeah. If she has an urge to eat dirt, she's probably got some iron deficiency, right? Or chewing on ice. Have you ever had anemia in your life, any of you, and you were chewing on ice? Yes, me. Really wanted to eat that ice.
Yeah, I did too when I was pregnant. But when I had my son, I stopped eating ice. Like he eats the ice now. So it's kind of weird.
Okay, you know how important folic acid is. Folic acid is vitamin B9, critical for cellular growth. We all need folic acid. But if a pregnant woman makes sure she's getting her 400 micrograms a day before she gets pregnant. Because by the time she realizes she's pregnant, that baby's almost fully developed. Okay, so we need it before then. Folic acid, beans, citrus, legumes. This is inadequate folic acid can lead to spina bifida. This is a picture with a baby on the right that's got a myelomeningocele, where the neural tube did not close right at the base of the cord, and the nerves were exposed. So these babies usually have surgery right after delivery. Shortly after, within 24 hours, they're going to have surgery to replace those cords. And it depends where that defect is on their back, where the meningocele is. It could be higher up on their back, and usually that's an indication that they're not going to walk. Okay, teen pregnancy, always think about growth, restriction, poor nutrition. Okay, we're going to teach your good nutrition. You might want to recommend referral to a dietitian so that we can prevent IUGR. We need her to come in more often to check her weight. We want her to gain the weight she needs to gain. Okay, so a lot of teaching, a lot of support. Nausea and vomiting of pregnancy can get so bad. When you vomit and you regurgitate, you're actually throwing up acid that's normally in your stomach, hydrochloric acid. And the loss of all this acid also is the loss of potassium. And so women who have severe nausea and vomiting cannot keep anything down, severely dehydrated. It's called hyperemesis gravidarum. So the priority is get an IV started. Okay, replace her potassium, give her some fluids, and treat the nausea. Okay. Exercising during pregnancy. Brisk walking. If she's used to doing certain kind of exercises, it's acceptable within reason. But if it's pretty vigorous, she's going to feel the need to slow down the farther along she gets in her pregnancy, because ligaments change, right? They're more relaxed. She could pull a muscle. Know your normal BMI. Okay, normal weight BMI is 18.5 to 24.99. For the first trimester, she needs to gain up to 4 pounds. Sometimes women have so much trouble with nausea, they don't gain that weight. But hopefully they'll put it on in the second and third trimesters. And then about 1 to 2 pounds a week after that. So remember, poor nutrition can lead to intrauterine growth restriction and preeclampsia. So we want to teach our client about how to eat. How can we teach our clients how to eat in pregnancy? Well, if she has a lot of trouble with pyrosis, heartburn, what would you teach about heartburn?
Not to eat right before bed or lay down right after eating.
That's a good idea, especially the farther she gets along in her pregnancy when there's not that much room in her stomach.
Try and stay away from acidic foods.
Okay, start to stay away from those foods that are very acidic or very spicy. What else is good to teach? Just maybe eat smaller meals throughout the day. Don't eat large meals. You eat a smaller meal, and maybe more meals, which is better for all of us to do. It controls your weight if you eat small meals throughout the day versus 2 large meals. Okay, iron supplements is important. What, 300 to 400 more calories during pregnancy is required usually to get those complex carbohydrate in. So buprenorphine and methadone are the drugs of choice during pregnancy for those clients who are addicted or dependent upon opioids. If we can get them to take a substitute, it's much safer for that baby and for them. And then that baby's not going to experience the withdrawals. At least they're not going to be near severe. And then we want her to breastfeed, right? Torch infections, just know these are the infections that are acquired during the pregnancy. This is what baby can contract during the pregnancy. And they usually kind of present in the same manner: rashes, eye manifestations. Preterm labor. Signs and symptoms: low back pain, low back pressure, okay, increased pelvic pressure. How do you differentiate true and false labor?
False labor will get better, like with walking and drinking more water.
Okay, yeah. I've sent many clients to the OB unit. They call and said they're having contractions and it's too early. I said, well, go to the hospital, go to the OB floor, and we just give them a bag of fluid and their contractions go away. So, encourage them to drink a lot more water. Okay, good. So regular cervical dilation, regular contractions with cervical dilations is true labor. The 5 P's of labor. The passage or the passageway, mom's anatomy, the size, the passenger, the fetus, the position, the lie, the presentation, the size, mom's position. Is she allowing gravity to help with fetal descent during that second stage? And then the powers. What's the primary power of labor? Who remembers the primary power of labor?
Are we speaking of contractions?
Contractions, yeah. What's a secondary power?
Properties, which helps us, right?
Pushing?
Pushing, yes, pushing. All right, and then just some pictures that have talking about different stages of labor. Stage 1 is labor, stage 2 is delivery of the baby, stage 3 is placenta, stage 4 is postpartum for 2 hours, immediate postpartum period. Fetal heart rate variability, the importance of moderate variability, which is the one on the bottom in the middle here. The one on the top is minimal variability, and then moderate, and then marked. I've got my slides saved in there. Slide serve. So moderate variability is what we want to see. We want to see the fetal heart rate change. So what affects fetal oxygenation? So when you think about the oxygenation of the fetus, it comes from the blood, right? Blood from the placenta. Baby doesn't breathe. Okay, it's in the blood, the oxygenation in the blood. So what affects fetal oxygenation is blood flow from the uterus. Okay, is it adequate? When she has a contraction, does that placenta fill right back up quickly? And that means there'll be adequate oxygenation and you won't see any late decelerations. Okay. So late decelerations means that the baby's heart rate drops as the contraction is subsiding. In other words, that placenta is not perfusing very quickly. Okay, it's inadequate. It's insufficient. Okay. Field chop. Just have to memorize it. So if you see variable decelerations on the monitor, and those are the sharp V's, and they occur between contractions, during a contraction, doesn't matter. It's not related to the contraction. It's the cord being compressed. That's stopping the blood flow to the fetus. Okay. So you need to stop oxytocin if she's receiving it and change the position. So if it's a cord compression, what position would you change your mother to?
Or left side.
Into chest.
Knee chest, if it's cord compression. If it's a late deceleration, the one on the bottom, what position?
To the left lateral.
Yeah, the left lateral. Yeah. Cesarean sections are invasive surgery, so you need consent for the anesthesia and consent for the procedure itself. So you really need to explain to your client who has a scheduled C-section what to expect. If this is her first baby and it's determined that she needs a C-section, then we need to teach her what to expect. The provider needs to teach her the risk of a C-section. Anesthesia needs to teach her the risk, what's expected when we do an epidural or a spinal. We need to talk to her about MPO status. And then we certainly need to explain to her the need for a Foley and sequential compression devices on the legs. And then immediately post-op, when she comes back to us, we need to monitor her for sleepiness. Okay. Hygiene, incision care, discharge. We recommend that mothers don't do vigorous exercises for at least 8 weeks after surgery. And even then, it's recommended she not do vigorous, but kind of slowly work up. Abdominal muscles, take a long time to heal from C-sections. Postpartum priority. Remember, if the uterus is boggy, you need to massage. Assess the bladder. That's your secondary priority. The fundus and then the bladder. Okay. Make sure you explain to mom the importance of emptying that bladder. So oxytocin and methergin or methylgranavine. So know your uterotonic drugs and signs and symptoms of hypovolemia or hemorrhagic shock. So I'm going to leave this picture up here. Let's take a break. It's been an hour since I've been doing a lot of talking. We'll take a break. We're not quite finished halfway through, so we have plenty of time. So let's take a break until 10 after the hour. 10 after 4, 10 after 3, wherever you are in this United States. Did you come up with any questions during your break or anything that you wanted to ask? Okay. All righty. So remember the signs of shock, whether it's hypovolemic, hemorrhagic, cardiogenic, anything that reduces blood flow and stops the heart beating. Tachycardia, cool, clammy, tachypnea, pale skin, pallor. Pallor is another word for pale. Okay, so get an IV started. Begin your uterine massage. Check the bladder. Empty the bladder. Okay. And then use some uterotonic medications. So oxytocin would be your first line, a bolus intramuscularly, and then we can do IV at a high rate. And methylphenidate, prostaglandins. Weigh the pad so you know how much she's bleeding. Okay. Once you know that her bleeding is under control, we're going to continue to monitor the lochia, encouraging her to change her pad every time she gets up. Okay, usually that first few days, it's called rubra, dark red. And then it lightens up to serosa and then alba for about a month. Okay, assess the perineum for any lacerations. Okay, and hematomas. Assess her hemorrhoids. Usually they begin to subside after pregnancy, after delivery. And then wash your hands and begin teaching and monitoring, observing mother-baby bonding, breastfeeding. Is she holding the baby in the right position? Is the baby latching on correctly?
That was one of my experience this week at clinicals, helping the baby to latch on and helping to
good.
stimulate the baby for the mom.
Yeah,
It was fun.
great. Great. Yeah. So oxytocin, we use it to help the uterus contract, but it also causes the expression of milk. Okay. So when baby sucks, it draws the milk, oxytocin is released, causes uterine contractions, and the continued production of milk with prolactin on board. Okay. Remember the benefits of colostrum. What's one benefit of colostrum?
Digestive enzymes.
Digestive enzymes. What else?
Antibodies.
Yes, and immunoglobulins, antibodies. Breast milk. Remember what the benefit of colostrum is for bilirubinemia. Bilirubin levels. How do we help baby release bilirubin?
Breast milk.
Breast milk, feeding the baby. Yeah, through the stool. And colostrum is a laxative, so that helps release the stool quicker. So a non-breastfeeding mother, we're going to use cool compresses, a very supporting bra. She could even put like an ACE wrap around her breast and bind them. No stimulation, okay? But if she's breastfeeding, we want her to avoid estrogen. If she takes estrogen, it's going to reduce milk production, okay? Estrogen levels need to remain low for a while so prolactin can climb up and make milk. Other things that can cause bleeding during pregnancy is a molar pregnancy. It's not a true pregnancy. Okay. To remember some of the signs of a molar pregnancy, hydatidiform pregnancy. It's on here. Larger uterus, HCG levels are much higher than what you would expect early in the pregnancy. Nausea and vomiting, bleeding. What are some signs of ectopic pregnancy? What's usually the first sign?
Pain.
Stabbing
Pain.
pain in the lower
Yeah.
abdomen.
Yeah, the pelvic pain. So what are some choices of treatment? The pregnancy can't continue on. What do we do usually? There are two options.
They can give medication like misoprostol to help the baby like calm down and be like released, and then
Expel.
they can also do surgery and
Yes.
remove the part that is affected the pregnancy.
Yeah. So we can use, of course, now with the controversy in the law, you need to, as a reminder as nurses, we need to know our state laws. If you're practicing in Pensacola, if you're practicing in Columbia, wherever you are, what state you reside in, you need to know the nursing laws in that state. Because some states will allow you to use mifepristone and misoprostol, okay, to help with a medical abortion. A spontaneous, inevitable abortion. What are some symptoms and signs of inevitable abortion? In other words, it's going to happen. So how do you know?
Bleeding.
Rupture
A
of
lot of
membrane.
bleeding, pain, contractions, pain, and the cervix is open, okay? Whereas a threatened abortion, there might be some bleeding, but there's no pain, and the cervix is closed. It's threatened, but it's not inevitable. Okay. Placenta previa, so location of a placenta. If it's going to be down low, part of that placenta is going to be hanging over the os. So we're going to monitor for bleeding and teach our client to monitor for bleeding and let us know. It compromises the placenta. Okay. In other words, that placenta is not going to be completely perfused, that portion that's overlying the os, the internal os, the opening of the cervix. She's going to have a lot of pelvic pressure. Okay, so placenta previa, painless bleeding. It's not painful. She'll feel pelvic pressure, but not pain. And then the thing we didn't really talk about much because it wasn't on any of your exam was the placenta when it attaches to the endometrium, when it's enclosed by the endometrium. It can actually, those placental blood vessels can actually grow deeper into the uterus. It's called accreta. Okay, and it can be so deep that in order to deliver the baby, we have to do a C-section. And if it's an increta or a percreta, we're actually going to have to remove the uterus too, because there's no way of separating the placenta from the uterus. Okay, so if she has a placenta with an accreta, increta, or a percreta, if it's attached too deeply to the endometrial and into the myometria tissue, we have to actually do a C-section and a hysterectomy at the same time. So if you had a client with a previa that was bleeding a little bit, and she called the office, she said she's bleeding, what would you expect to be ordered? If she's bleeding, she knows she has a previa, because she had come in the week before and we did an ultrasound and we noticed the previa, what would you expect to be ordered?
Ultrasound.
Yeah, we do an ultrasound, but what else do we need to look at?
Labs.
Not necessarily labs. So if part of the
Maybe
placenta,
she needs to rest and put the legs up.
we need to do a fetal assessment, don't we? To make sure that that bleeding is not compromising the fetus. Yeah, we need to do a fetal assessment. So we could do a BPP, make sure there's no decelerations. Okay, so we need to do a fetal assessment and go from there. Whereas the placental abruption, if it's done, if the placenta pulls away abruptly, in other words, it's an acute situation, either from trauma, or maybe she had abruption before, or she uses cocaine, some kind of very strong vasoconstrictive drug that can cause an abruption. This is emergency, so we have to do a cesarean section because there's a lot of blood loss. So what would be one of the first things that you would observe if you suspected an abruption?
Severe abdominal pain and dark red bleeding.
Okay, severe abdominal pain, dark red bleeding. And then what are some other observations or assessments that you would find?
A rigid board-like abdomen and fetal distress.
Hey, yeah, perfect. Yes, exactly. So we've got, she's hemorrhaging and the baby's losing blood, mom's losing blood, and they can lose a lot of blood. Just think about all the blood that's in the uterus. Okay. There might be a liter of blood just in the uterus. And it deprives the fetus of oxygen if there's no blood flow to it. Okay, so we have to do a C-section. Placental abruption can also lead to DIC, disseminated intravascular coagulation, or it could lead to an embolus, right? Remember, DIC starts out with clotting everywhere and then ends up with bleeding everywhere. Okay, so we have to treat DIC as a hemorrhage. Okay, IV site, extra IVs, blood work, oxygen, lots of fluid. Okay. So diabetes is hyperglycemia, right? Too much glucose, free floating, free circulating, not enough insulin to open the cell. So risk associated with diabetes in pregnancy. So if hyperglycemia is occurring early in pregnancy, during organogenesis, during those first 8 weeks of the pregnancy, what are some potential outcomes?
Neonatal hypoglycemia.
Well, before we get there, at the beginning of the pregnancy, during the antepartum, early during organogenesis, if mom has high blood glucose, what does that do?
The baby's going to be big. macrophytus.
Okay, we're talking about early during those first 8 weeks. Hyperglycemia. What if her A1C right before she got pregnant was 8 or 9? In other words, high.
She's gonna have to take insulin, isn't she?
Yeah, yeah. Or
Should the
something,
demand
yeah.
be low?
So she's going to have, her baby's going to have some congenital defects, right? Remember that? Congenital defects. So heart defects, some kind of abdominal defect. Okay, because it's during the development of the structures, and high glucose levels affects the anatomy of the baby that early in pregnancy. So that's why preconception counseling is critical for diabetics. Okay. So insulin needs at the very beginning of the pregnancy are usually lower for the first 7 weeks or so. Once she gets closer to the 20th week of her pregnancy, that's when insulin needs are increasing. Okay, she needs more insulin because the cells are resisting the insulin that's available. So we need to give more to get that sugar into the cells. So after week 20, if hyperglycemia occurs then and it wasn't present earlier in the pregnancy, in other words, no diabetes in the past, it's just a normal euglycemic person becomes diabetic during pregnancy, we call it gestational diabetes. Okay, so it's occurring afterwards when the demands for insulin are higher. That's when she can develop diabetes if she can't supply enough insulin. Okay, so sometimes we can just control it with diet, okay, and exercise. But other times, a gestational diabetic might need medications. Same thing with high blood pressure. If she has it in the first 20 weeks with the early pregnancy, first trimester, if she has high blood pressure, then she probably had it before she got pregnant. Okay. But if she doesn't have high blood pressure and yet she develops it after the 20th week, it's considered gestational hypertension. Okay. And sometimes we treat it, depends how high it is. Because it also could be a sign of preeclampsia, right? Later in pregnancy. So that for a diabetic, whether it's pregestational or gestational diabetes, or pregestational hyperglycemia, or gestational hyperglycemia, the number one goal is what? What's the number one goal for a client with hyperglycemia?
Management of blood sugar.
To keep it under control during the pregnancy, the blood sugar.
Yeah, strict glycemic control. Okay, we're much more strict in diabetes. So how do we define gestational hypertension? We know when it occurs. What blood pressure is considered high in pregnancy?
Is it 140?
Over 90. Either above 140 or above 90, or both. Okay. Preeclampsia, then, one of the first signs is high blood pressure. Common symptoms, early symptoms, headache, visual changes. What are some other signs of preeclampsia?
Headache?
Yeah, we said headache. Yeah, headache. What are some other signs? They're up, they're on the screen. Can you see the screen?
Visual changes.
Blurred vision,
Okay,
Abdominal
Edema.
pain.
okay, so pulmonary edema, deep tendon reflexes, 3+ or greater. Okay. Liver enzymes elevated, low platelets, creatinine levels are high, proteinuria, and then peripheral edema. Okay. Do y'all hear on the news today, one of the former Olympians died with eclampsia? I just heard it on the news. She was at home. So I don't know, the news doesn't go into details. We only hear bits and pieces. We just don't hear of that today. People dying from preeclampsia. But I wondered if she, went to her provider often enough, if they knew she had it. So she was at home and she went into seizure activity, and both her and her baby died. It's sad. I don't know the Olympian who it was, but kind of unheard of. Okay, if you have a client with preeclampsia, our care plan is such that they're at risk for fetal and or maternal injury, right? Related to seizure activity and poor oxygenation. During a seizure, if it's a grand mal, your client might not be breathing. Chances are they're not for the time during the seizure. 1 or 2 minutes. And normally that's not a problem. But we don't want it to happen if we can prevent it. Okay. So we have to be prepared if she does have a seizure. Okay. Seizure precautions. Rails up and padded. The bed is down. Suction tubing available, and it works. The wall suction works. Make sure you check your equipment. Make sure the oxygen meter works in the room. Make sure you have tubing and a mask.
He came on drunk too, like stumbling and shit. I came from work.
Hot mic.
And his wife was like, what are you doing?
Okay.
If I
So
hit
we
him from the
treat,
front, from the back. Look at my car. You sent me around in front of my car?
Check
we
your mic,
treat,
y'all.
we treat medical intervention for preeclampsia. So the discussion question about your client that was a diabetic, she was showing signs of preeclampsia. So our priority is assessing where she was with the preeclampsia and making management plans. So we have to teach and explain to her if her blood pressure goes up or if her headaches worsen. So the medical intervention would be magnesium. Okay. So knowing the signs of preeclampsia, those are the symptoms and signs we're monitoring for while we give magnesium. Okay. So the signs and symptoms of preeclampsia: headaches, protein in the urine, hyperactive reflexes. Okay. Give magnesium. Does she have a headache? What's her respiratory rate? What's her urine output? Any visual changes? What's her deep tendon reflexes? So those are the things you monitor when you have a client on magnesium. When you have a client on oxytocin, you're going to monitor the contractions, frequency, strength, duration. Is a baby tolerating the contractions? With magnesium, we're monitoring headaches, protein in the urine, urine output. Remember, magnesium is a central nervous system depressant. So we're depressing the activity or the irritability of the brain by improving perfusion. And it's the brain that tells the body when to breathe. It regulates blood pressure. It regulates respirations,
No fucking
heart
Johnny.
rate.
The fuck?
So when we depress the brain, we might be
All that shit.
depressing too much.
The lady told the wife told him that, babe, let's go.
Who's got background noise on? I'm gonna mute everybody, okay? So when we're given magnesium, because it's a central nervous system depressant, we need to make sure we're not given too much and she becomes toxic, which would depress the central nervous system, okay? Depresses the blood pressure, depresses the respiratory rate, depresses the heart rate. So you might see hypotension, respiratory depression. You might see bradycardia. You might see no urine output. Okay, so you're doing too much magnesium. So that's why we have to monitor all the signs and symptoms while our client is receiving magnesium. So in your rounds, when you're checking on your client, you notice she's on magnesium 1 gram an hour, and yet her deep tendon reflexes seem to be still hyperactive. She is complaining of a headache still. She's been on magnesium for an hour and a half, and it's not helping. What would you do? She still has a headache. She has visual symptoms. She has high blood pressure. Her deep tendon reflexes are a 3+. She's been on her magnesium for an hour and a half at 1 gram an hour. What would you do?
Contact the doctor.
Yeah, you're going to let the provider know that she probably needs a higher dose. Okay. And he'll probably want you to draw a magnesium level and increase it by 1 gram an hour. So give her 2 grams an hour, get it going, and make sure you draw the blood before you increase the magnesium level. And so you're going to continue to monitor those same signs, okay, so that she won't get too much. Okay. Premature rupture of the membranes. If the membranes rupture and she's not in labor within an hour, it's a premature rupture. And it increases the risk for the invasion of the vaginal bacteria into the amniotic fluid. Okay. Or it could also be invasion from the skin. Okay. So premature rupture. Premature rupture also could lead to a prolapsed umbilical cord because the fluid is drained out. Gravity pulls everything down. What are the clinical findings of chorioamnionitis? What would you see? What would your assessment be if you are suspecting the development of chorioamnionitis, an infection? What would you see?
The amniotic fluid, it's gonna have a smell. It's gonna smell.
Okay, foul odor to the amniotic fluid. What else?
It's changing color.
Color changes, maybe.
What about a fever?
Fever, absolutely, a fever.
And tachycardia.
Maybe tachycardia, absolutely. Fetal and maternal. What else? One more thing. What else might you see?
Tachycardia.
Tenderness, tenderness,
Tenderness of the uterus. Yeah, if you touch your uterus, it's going to be tender. Yes. How do we treat it?
antibiotics,
Yeah. So penicillins, clindamycin, maybe vancomycin if she's allergic to those drugs. We certainly want to get labor going. Okay. We want labor to be very progressive so that we are protecting the baby. Okay. All right, preterm labor. So we know preterm labor signs, low back pain. If we have a client that has had a preterm labor before, or family history of preterm labor, or a young person, an older person, perhaps a diabetic, or incompetent cervix that wasn't corrected with a cerclage. It's inevitable. If her membranes are still intact and there's no sign of infection, we're going to try to maintain the pregnancy as long as we can. So we might put her in the hospital and keep her there, give her medications to stop labor. We can try terbutaline, as long as she doesn't have high blood pressure, right? Or some kind of cardiac disease. We can also use other drugs to suppress uterine activity. Anything that's anti-inflammatory, calcium channel blockers are good. They help the uterus relax, like nifedipine. Magnesium helps the uterus relax a little bit. But why else do we want to give magnesium for preterm?
to protect the baby's brain.
Yeah, neuroprotection for the brain. Remember what magnesium does when we give it for preeclampsia. It improves cerebral perfusion, okay? It improves the perfusion of oxygenated blood to the brain, okay? So when we give it to mother, we're giving it to baby, right? Antibiotics. And then betamethasone, steroid injection to mother, and that's for the baby, okay?
For the lungs.
For the baby's lungs, yeah, to stimulate surfactant production. So if we're given a steroid, we also need to give an antibiotic, right? If you go to the doctor because you've had a sinus, you think you have a sinus infection, you've had discolored yellow-green nasal discharge, you got a headache, pressure in your head, and it's been going on for a week. You go to the doctor, he's going to maybe just put you on a steroid for a while to get rid of the inflammation, right? But if your drainage becomes worse and more purulent, meaning you have an infection, then he's got to give you an antibiotic. A lot of viral type rhinovirus can be treated with steroids only. Okay, but if it continues even after that, we need a antibiotic. But with preterm babies, we need both, okay, at the same time. Most preterm babies, most preterm labor is caused by an infection. And it's usually the number one reason a baby goes to NICU is because they're preterm. Okay, what if we have a client that's 41 weeks and she has agreed to let us induce her? We want to deliver this baby. It's getting late, 41 weeks, more than enough time. In order to induce her, we have to use the Bishop score to assess her cervix, right? We want the cervix to be partially ready for a contraction. We don't want it to be firm. We don't want it to be closed. We don't want it to be not effaced at all. We want it We want to ripen it up. Okay. So we use the Bishop score for that. So anything above a 5, there's a chance for success, but we like it closer to 7. Okay, a Bishop score. You don't have to really know all the criteria. Just know it's an assessment of the cervix. Is it dilated? Is it effaced? What's the position? Is it anterior or posterior? What's the fetal station? Okay. Once we know that, if we hit that 7, number 7, there's no standard number, by the way. If we know we've got a cervix that's beginning to dilate and beginning to efface, then we can go ahead and start oxytocin. Do you remember the drug we use to ripen the cervix? What do we use to make that cervix dilate and efface?
Prostaglandins.
Prostaglandins, yeah, like misoprostol. Misoprostol. Okay. We can use prostaglandins, and that helps that cervix begin to dilate before we put her in labor. That's what we call labor induction. Okay. So we dose oxytocin in milliunits. That's the first step that you need to do when you're calculating oxytocin infusions. Okay. Milliunits a minute. Once you get the number, once you figure out how many mLs you need to give your client the amount of milliunits that's ordered, then you have to multiply by 60 to get the hourly rate. Okay, so usually it's start out with 1 to 2 milliunits a minute. Okay. So high risk delivery, protracted labor, or a baby that won't rotate. Sometimes we have to use instrumentation, we call it. So vacuum assisted delivery is safer than forceps, but both can cause maternal and baby injury. Shoulder dystocia. There's a lot of good pictures in your book and online with shoulder dystocia. There's no reason for you not to understand what's going on. In this picture, you see that that baby's anterior shoulder is pushing up against that pubic bone. If we push down on that arm, right above the pubic bone, gentle pressure, that helps move those shoulders together. But we might inadvertently fracture that clavicle on that side, or the humerus. Okay, it's a potential injury. But it's better to do that than not to get that baby delivered. Okay, you also might see the turtle sign. The baby's head goes out, but then it pops back in because that shoulder is in the way, or the pubic bone is in the way. So we do the hips and knees flexed, suprapubic pressure. Uterine rupture. If there's scar tissue on the uterus, in the uterine muscle, it could tear if you during labor. It's rare. Uterine rupture is very rare. Okay, and here's a lot of reasons it could happen. Big baby, external conversion, oxytocin, too many contractions occurring too often or too strong. Amniotic fluid bolus. Remember, a bolus is a foreign object that's circulating in the blood. An embolus is blood in particular. Amniotic fluid embolus is a bubble, or the amniotic fluid is the embolus that's headed to the pulmonary artery. So respiratory collapse. Dyspnea is usually one of the first signs. And this is going to happen after delivery. Super rare, I've never seen it, but the outcome is usually poor. And then your deep vein thrombosis. Make sure you're assessing the extremities postpartum for any DVT. What is maybe one of the first things that you might observe with a DVT?
Leg pain.
Leg pain, uh-huh.
Swelling,
Some edema, yeah, some edema.
shortness of breath.
For deep vein thrombosis in the leg, you're not going to see shortness of breath.
You'll see redness and warmth at the site.
Okay. So your superficial thrombosis of the saphenous vein, or a superficial vein, I should say, we usually don't intervene on those. They're painful, but they do resolve in time. ITP, immune thrombocytopenia purpura. There's a good picture right here. Purpura is like a collection of petechiae. It's like a discoloration. So ITP is treated with steroids, and then we might have to replace the platelets if it becomes severe. Usually there are signs of ITP during pregnancy if your client has that chronic disease, where ITP is the immune system that shortens the life of platelets. So they tend to bleed, okay? So we're prepared when she goes in to deliver her baby, okay? We know she has ITP, and we might give her steroids at the time. But remember what happens when we give steroids. It increases the risk for infection, okay? So a DVT needs anticoagulant, okay? Heparin infusion or Lovenox. I don't know what the latest treatment is. Anybody experienced that during clinical? Anybody with a DVT? And then we have our postpartum infections. So any client that develops a fever after the first 24 hours delivery, okay, after the first 24 hours, and then it has a fever for a couple days, temperature above 100.4. It's not uncommon to have a temperature of 99 to 100 maybe after surgery. But if it creeps up beyond that, then we need to, your client needs to let us know. Endometritis is the most common postpartum infection. Okay, that's the uterus infection usually from a cesarean section. Okay, so if we do a C-section and we don't do prophylactic antibiotics, there's an increase for infection. Many years ago, they began a protocol to prevent surgical site infections. So they came up with every client that goes to surgery needs to have an antibiotic infusing at the time of the surgical incision, okay? So we roll the patient into the OR, we've got the antibiotic infusing, and when we get everything ready, we make our incision. That's the best time to have that prophylactic antibody running. So with a C-section, we're going to get everything ready, get the patient all ready to go, fully in, abdomen shaved if we have to, and SCD's on, all the consents are signed, and we roll her in, we start an antibiotic, IV, and then we make our C-section incision. Okay, and that helps prevent endometritis. Okay, but some of the things you're going to see is just a fever. Okay, a fever. Make sure you're teaching your client about assessing any wounds, like a C-section incision when she goes home. Drainage is expected for a couple days, as long as it's clear. We usually put a peri pad on top of that site, and she can use a peri pad at home. Then when it stops draining, then she doesn't have to keep it covered. This is a picture of an actual skin infection that's beginning. Urinary tract infections. So we're going to teach our client how to prevent them. How do we do that?
Don't wait till your bladder's full to urinate.
Yeah, empty your bladder frequently, right? Drink extra fluids, eat well, okay? Pericare, wipe front to back, all those things.
Use cotton underwear.
Cotton underwear, yeah, something that breathes. Clogged milk ducts and a mastitis. You're going to have the same symptoms, right? Fever. Okay, redness on the breast. What do we teach for mastitis?
Continue breastfeeding.
Okay, continue breastfeeding, yes.
Cool
What else?
compresses.
Okay, okay. Janique, are you still here? Janique is hiding behind.
Do you see me on that little screen thingy?
No?
It comes in and out.
Okay. All right, postpartum mood disorders. What differentiates psychosis from depression?
Psychosis has bizarre behaviors.
Hearing voices.
Yeah, yeah. Impulsive, delusional, hallucinations, bizarre behavior. Suicidal ideation can occur with both depression and psychosis. Okay, suicidal ideation or infanticidal or homicidal. Okay. Apgar, babies. So we look at their appearance, their color, their heart rate, reflex activity, grimaces. Do they respond to stimulation when we suction their mouth and their nose? Do they withdraw a little bit? That's a good sign, okay? Activity, are they moving their arms and their legs? Respirations, good cry. So anything less than 3 is considered critical distress. A 7 and above, they're all right usually. And then 4 to 6 would be a moderate distress. Respiratory distress in the neonate. We have a diabetic mother. Her baby is hypoglycemic. So we're going to encourage her. We really want her to breastfeed. The best thing for that newborn. Within an hour after delivery, an hour or two after delivery, and then every 2 hours or so for the first week, anyway. So neonatal respiratory distress, signs and symptoms. What are they?
Nasal flaring, grunting,
Nasal flaring. Good.
retractions,
Retractions, subcosal, intercostal. What else?
That seesaw.
Seesaw respirations. Belly and chest are not synchronous. What else?
I said grunting,
Grunting and stridor, noisy. And then the last one is going to be what? What about the rate of respirations?
tachypnic,
Tachypnic, either above 60 or below 30, right? Okay. Signs of cold stress, hypothermia. The baby is cool to touch, skin mottles. You can see mottling of the skin also with neonatal abstinence syndrome. Central cyanosis, decreased responsiveness, jittery, tachypnea. And then know the modes of heat loss in the newborn. Evaporation, we got to keep our baby dry. Convection, reduce drafts. Conduction, don't touch that, let that baby touch anything cold. And then radiation, keep that baby away from cold objects. Signs of cold stress or cold stress, hypothermia leads to acidosis. And our preterm, our preterm babies are more susceptible to cold stress and acidosis. They don't have any reserves, no fat reserves. So the first 2 hours, we're going to vigorously dry our baby and put them on mother's chest. Okay. If you chose either one of those answers, you got that question correct. Maybe suction if we need to help clear the nares out, the mouth. We're going to do the mouth first. Okay. Ventilate your baby. Positive pressure. In other words, we're going to use a mask and a bag, and we're going to squeeze that bag and hold it for a few seconds and then release it. Keep that baby warm. What's hypothermia? Who's more prone to hypothermia? What did I say?
Preterm baby.
Preterm babies, yeah. They, even if they're sick with an infection, they might become hypothermic. Okay. Don't wait for a preterm to have a fever if you suspect. If a preterm doesn't act like it wants to feed, is a little lethargic, it could be cold stress, not necessarily hypoglycemia. And it could be an infection. Eyes and thighs. We give vitamin K by intramuscular injection and erythromycin ointment in the eyes, usually hopefully within those first 2 hours. Be familiar with newborn reflexes. What's the moral reflex?
when the baby's startled,
Yeah, a startle reflex. They'll reach their arms out like this. Babinski reflex is normal in a newborn. They fan their toes. Okay, not normal in adult. Okay, so vitamin K is what our body uses to produce prothrombin. Okay, to help the liver produce prothrombin. A newborn does not have any bacteria in the gut to make vitamin K. So we have to give them vitamin K in order to make prothrombin, which is a clotting factor. Okay. So hyperbilirubinemia, too much bilirubin in the tissue. A newborn has an immature liver. That liver cannot conjugate the bilirubin, cannot connect it with a protein. So it's released in the stool. So the bilirubin tends to collect in the tissue, free bilirubin. Okay, so when a red blood cell is broken down, so newborns, their red blood cells break down faster than yours and mine. Okay, our red blood cells usually live about 120 days. A newborn's doesn't. And if they have any kind of, most of them will have a little extra bilirubin on board anyway from hemolysis, just because they have a lot of red blood cells if we do cord delay. Okay, it might not be obvious. Okay, if we feed them, if they're breastfeeding colostrum, they're going to produce stool, and that stool is going to pull that excess bilirubin out of their system. So we promote feeding for hyperbilirubinemia, plus phototherapy, ultraviolet therapy. So there's this baby down here's got a billy blanket on. What if a baby is born with, or I should say, jaundice develops within 24 hours of delivery? What are your concerns? So a pathologic jaundice, in other words, if you notice your baby becoming jaundice within that first 24 hours, it's a pathological jaundice. We don't expect physiological jaundice for a few days. Okay, and that's usually associated with breastfeeding. But a pathological jaundice means that something occurred during the pregnancy. What was occurring during the pregnancy?
Maybe infection.
Like liver problems? Didn't develop or something? Or? No.
No, the blood is being, the mother's liver takes care of the bilirubin during the pregnancy. What causes hemolysis during pregnancy? What causes the baby's red blood cells to break down during pregnancy? How can a fetus become anemic during pregnancy?
Sickle cell?
Well, I guess it could be sickle cell. But usually, what is it? If I remember what causes pathologic jaundice? ABO, blood type incompatibility between mother and baby. Okay. So in a previous pregnancy, if she's Rh negative and she had a baby that was Rh positive, and after delivery, she did not get her RhoGAM, then her body now has Rh or that kind of blood type antibodies. And if she gets pregnant again during that pregnancy, those antibodies are going to work on that baby and destroy the baby's red blood cells. So it's called hemolysis. Okay, so baby becomes anemic during that pregnancy, and it can be pretty severe. It's called hydrops fetalis that can develop after delivery. As long as that baby's in utero, the bilirubin that collects is being released by the mother's liver. Okay, but once that baby's born, that baby's liver can no longer get rid of or cannot get rid of that bilirubin. So they become pathologic. They become jaundiced within the first 24 hours, and they're very anemic. So just remember that pathologic jaundice occurs within the first 24 hours, usually associated with blood incompatibility, okay, during the pregnancy. Because mom didn't get a Rogan from the pregnancy before. If she got her Rogan, then she wouldn't have those antibodies on board. Okay. All right. So assessing our newborn. Don't get hung up on the details. Just know some of the abnormals. Some of the normals, like fontanelles. There's 2 of them. That's palpable. The frontal and the posterior. They can be an indication of dehydration or intracranial bleeding. Okay. Molding. We talked about breast milk already, antimicrobial or immunoglobulins. What's the difference between a caput, succedaneum, and a cephalohematoma? What's the difference between the two?
The cephalohematoma doesn't pass suture lines.
Okay, which one doesn't cross the suture lines?
Cephalohematoma.
Yeah. So, you know, in this picture on the right where it shows the fontanelles, you know, those divisions between the bone, the parietal bone, the frontal bone, those are called sutures. Okay, because they're not, they haven't, what do you call it?
Fused.
Fused. Thank you. They've not fused that. They have to be separate so that during the delivery they can kind of overlap. But once they're born, within a month or 2, they're beginning to fuse. Okay, so when we talk about a cephalohematoma not crossing the suture lines, that means that's the suture lines we're talking about. So in other words, a cephalohematoma might just be over the parietal lobe or the parietal section of the cranium. Okay, whereas a caput is covering it all. And the cephalahematomas, you might see some higher bilirubin levels develop. Okay. Collecting specimens. So we always go for the foot. We're going to warm the foot up first, right? We're going to warm it up. That helps those little capillaries dilate a little bit. Circumcision. Teaching about circumcision care and cord care before our clients go home. The cord, it needs to stay dry and clean. If it gets dirty, just rinse it off with water. Keep that diaper folded down. It'll fall off on its own. Circumcision, we use petroleum jelly to keep it moist. You don't want to force circumcision. You don't want to force any retraction of the foreskin at all. And the circumcision, you might see a little bit of bleeding, and that's normal. Just reinforce the dressing. Signs and symptoms of a newborn. Sickness. What are some things you would see in a newborn if you felt like they were developing an infection? What are some of the behavior changes?
Not
Tachypnea.
What?
Tachypnea.
Tachypnea? Something before that.
them not eating and being a little bit whiny.
Okay, okay. They lose interest in eating. Yeah, feeding changes. They lose interest in feeding. Uh-huh. And then lethargy. Okay, those are the two biggies. High-risk newborn, whether injury or neonatal sepsis. You all probably know a lot about the abstinence syndrome. You did a discussion on that and did pretty well. Here's just a picture of what ABO and RH incompatibility is about. So everybody has blood, a certain blood type. Like, let's look at O negative. So type O blood has no antigens on it. It's negative, O negative. Okay. O positive has the RH antigen on it. Okay. So does A positive, but A also has some other antigens that make it an A positive or an A type blood. Okay. A negative will have typical A antigens, but it's not going to have the RH antigen. Your blood has different kinds of antigens. Okay. Blood has just antigens attached to it. A B positive with RH. AB. Okay. And there's different kinds of RH. There's an RHD, RHC, so there's all kinds of antigens on cells. We're concerned mostly with blood incompatibility. Okay. So in this chart, a handy dandy chart to have tells you what kind of blood you can get. So if you are O negative blood, you can only receive O negative blood if you need a transfusion. If you're O positive, you can receive O negative or O positive. If you're AB positive, you can receive any kind of blood. That's why it's called the universal recipient. Okay. And O negative is considered the universal donor. Okay. So if we plant mother here, mother is the recipient and fetus is the donor. Okay. If mother is O positive and fetus is A negative, their blood is not compatible. Okay. So that's what this chart is. So if you have a client that you typed and crossed for blood, let's say they're getting blood and it's your client and your client was typed with B positive blood, what kind of blood can you give your client? B positive blood can receive what kind of blood?
O negative, O positive,
B negative, and B positive.
negative, B positive.
Yeah. Mm-hmm. Yeah. Uh-huh. Prematurity. We talked about treatment of prematurity. Let's talk about some of the poor outcomes other than respiratory distress and meconium aspiration. We have retinopathy of prematurity, which is basically immature blood vessels in the retina. If we expose those blood vessels on the retina to high pressures of oxygen, in other words, giving them oxygen above 21% can actually damage those eyes and blind and damage the retina, cause blindness. It's called retinopathy of prematurity. Okay. Necrotizing enterocolitis. So for babies receiving oxygen, if they have a tent, you need to cover their eyes because the eyes can absorb oxygen from the air. Okay. But we need to use lower pressures of oxygen or lower flow oxygen. Most of the time, babies need ventilatory support more than they need oxygenation. Okay. Okay, necrotizing enterocolitis is about the gut. It means that the gut is dying. Something's causing the colon or the small intestine, it's usually small intestines, to die off. And it's because they're not being perfused most of the time. We think that's what it is. So poor perfusion, necrotizing, or mother received a lot of antibiotics or baby has been receiving a lot of antibiotics and it caused overgrowth of bacteria. So with a baby with NEC, some early signs are going to be losing interest in eating, vomiting, the inability to contain food or milk, okay? A distended abdomen, very tympanic, a lot of gas, and of course obstruction, hypoactive bowel sounds. They're not going to pass any stool. If they do, it's going to be bloody. Usually they have to intervene surgically and remove the part of the intestine that's dying, and that's what this picture is. So the number two things we're concerned about: high risk and even low risk, respiratory, thermoregulation for our newborns. Okay, they don't know, they cannot produce their own heat well. They have no reserves. So we have to protect them from heat loss and support their respiratory efforts. Protect them from infection. Facilitate bonding. Here's your list of medications that you need to know. If you look these up in your text, it'll be better than looking them up in a drug book because it's going to be applicable to OB. If you look up nifedipine in your OB book, it's going to tell you when we use it in OB. Okay. Same thing with betamethasone. Okay. Lots of stuff, but that's a good slide presentation and help you kind of work on which of those areas. Okay, you don't understand bilirubin. Now you can go to your book and look it up if you don't understand, or ask me. Okay. So I will put this up, recording for this, and Nicole, I'll get you your recording too. And underneath, let me share my screen again. Welcome to week 10 announcement on Canvas. I've got the class schedules here, and what I've done, I put my recording for Monday and Professor McBride here, and then I'll add today all of the ones from today from everybody, recordings, so you can watch them. And then all those other PowerPoints. So Monday I did this first one, and today we did the best HESI presentation, and then Friday, I'm going to do the HESI key topics one and record it for you. And then I've got one more down here. There was a campus that asked me to teach, some students who are graduating, asked me to help them with a refresher for OB before they took their NCLEX. And so I developed a slide set, and that's what this one is at the bottom. So it's a good one too, right? Okay. All right. Anybody want to set up a time to meet with me in week 12? So,
Yes,